Okay, let's just, we're a small group. Let's just do it all together.
Great. Sounds good. So the chief concern we'll have you guys think through is weakness. And we're seeing a 71-year-old man who's got type 2 diabetes, hypertension, uncontrolled dyslipidemia, coming in with 3 weeks of weakness and fatigue. The story actually, he thinks, starts 6 weeks prior because his lipids had been fairly out of control. He was started on a statin medication. 1 week after that, he started having some muscle aches. And then 3 weeks after starting the medication, he actually started feeling weak, kind of in his shoulders. He thought maybe some shortness of breath, but had no other cardiopulmonary symptoms, chest pain, palpitations. Around that time, so now we're about 3 weeks after the meds started, a couple weeks into the symptoms, he also noticed a rash on his knuckles and his neck too. So he, at that time, really got worried. He stopped the medication in case that was related to what was going on, but then came in for evaluation because his symptoms kind of kept getting worse, and he even noted some swallowing difficulty. And I'll stop there, see what questions you guys have. What statin he was on? Thanks, Ravi. He was on 40 milligrams of atorvastatin.
I remember when I was a student, like, 10 plus, 10, 12 years ago, and everybody was on simvastatin, and specifically 80 milligrams of simvastatin. And everybody at the time also seemed to be on amlodipine. There was so much statin-induced rhabdo, and we don't see that very much anymore, do we? With atorva and Rasuva. But of course, that seemed to kind of be a heavy pull in the case, because this, by the way, just to be clear, this really sounds like muscular weakness, right? When people say weakness, again, it could be anything from fatigue, asthenia, to muscular weakness, to cardiopulmonary insufficiency, to recently I was discussing a case where I learned from a neurologist that oftentimes actually a bradykinesia and like basically hypertonia, dystonia can be experienced and feel like weakness just because you want to go and you can't really go. And this patient actually, who ended up having basal ganglia involvement with Wilson's disease and was kind of Parkinsonic, they kept referring to it as weakness, and they were debilitated from it. But on confrontational testing, it was full strength. So again, weakness, a very vague kind of chief complaint, but this you're most describing muscular weakness. So that's the presumption again. And then you mentioned statin early, obviously a lot of gravity there, but then the rash. So David, I guess, can you, or anybody else, can you describe more kind of why the skin stuff brought up dermatomyositis?
Well, we don't know yet too much about the rash, but these things about the distribution in the knuckles could be the Gordon's papillus, and the neck could be the next sign of the dermatomyositis. We have to see it, and we don't know the time course and other things, but yes, could be.
Absolutely, excellent. Yeah, so a lot of those kind of named rashes and dermatomyositis are in photosensitive areas, and part of the sort of like periorbital discolorations and stuff. Part of it can also just be like capillaritis, which dermatomyositis is sort of like some vasculitic overlap. And then the hands are really important, the typical kind of knuckle rashes that go transpapules, but also looking for other kind of skin changes, the mechanics hands that are associated with antisynthetase and other antibodies, looking very carefully at the nail beds and looking for tiny little dilated capillaries, little question marks and stuff, would really kind of narrow the differential on this exam to just a handful of autoimmune syndromes. So it's hard for me right now to kind of overcome that overlap of like weakness and kind of being described almost as like proximal weakness, and then this rash that sounds like dermatomyositis. And then I, like Austin, am also kind of struggling to say like, all right, well, were the statins a coincidence? Because statins can definitely trigger a necrotizing myopathy with not just like, any old rhabdo, but they can then trigger a self kind of an autonomous autoimmune myopathy associated with HMG-CoA autoantibodies, I believe, but that shouldn't come with a skin involvement that I know of. So I don't know if the statins were a coincidence in this case.
I think, yeah, kind of hearing you guys discuss this, the finding of the dermatologic symptoms is really important. And I just want to add to that bank of possible manifestations, of which you guys listed the key ones: the around the eye, also known as heliotropic, the front of the chest, known as V sign, the mechanics hands, both on the knuckles, but then some of the cuticle changes that you mentioned, like just raggedy looking cuticles even might stand out to the eye. But there's actually two not as sun exposed areas that are also important. There's, as well as the V sign on front, there's shawl sign on the back, where the whole upper back, even without sun exposure, can have the changes. And there's something called saddlebag sign, where the lateral side of the hip almost wear like a saddlebag if you were riding a horse, or a holster holding a gun would hit the sides of the thighs, and those are non-sun exposed areas. Big challenge too with these is if someone has more melanin in their skin versus not. This patient happened to be Caucasian, but some of those skin changes may look very subtle, may even just like look like swelling or edema of those areas. So you guys you picked up very quickly on the pathognomonic kind of findings specifically for dermatomyositis to worry about, and just wanted to add a couple more.
Thank you. And by the way, I just realized that the holster sign and the shawl sign are kind of analogous, right? It's like the proximal limb extensor surface.
Interesting. Yeah.
Right?
Yeah.
That's the lateral extensor surface of the. Okay. So what else? Any other thoughts, y'all? Myositis can be paraneoplastic. So can a lot of rashes. But and then of course dermatomyositis could be paraneoplastic as a syndrome itself. I guess let's move on, like fill out the rest of the history and how he looks.
Let me add a few more things that came up on just kind of running through symptoms that he hadn't mentioned initially. So over this 6-week time period, he has had 15 pounds or about 7 kilos of weight loss. I mentioned no fevers, chills, night sweats, no other constitutional symptoms. And then I did mention this new onset of dysphagia is what really brought him to the doctors. And I don't think we had unpacked that yet. So wanted to make sure that dysphagia was there too. Steph,
do you mind actually, Ravi, Austin, thanks for kind of catching that too. Let's talk about that. So Sarah's saying difficulty swallowing could be due to mass compressing the esophagus, and sure, or an esophageal mass itself, right? Intraluminal, and maybe that's the cancer to which everything else is paraneoplastic too. So the other thing, so Ravi, you're bringing up the fact that a lot of times when you have a predominance of bulbar muscle weakness, meaning muscles in the face, extraocular muscles, swallowing, the laryngeal muscles, presenting with blurry vision or dysphagia or dysphonia, hoarseness. A lot of times, those bulbar muscle weakness is associated with neuromuscular diseases, myasthenia. But whenever you have just any skeletal myopathy, those you can have bulbar muscle weakness associated as well. So I think it doesn't necessarily completely shift the focus for me. But it does, you definitely can't just assume that's muscular weakness, right? And it is worth elaborating and saying, is this sort of progressive solid dysphagia, which would be more, mass compression, something mechanical, or is it also with liquids? Is there a lot of kind of sputtering, choking, things like that, which would support more? Again, this is just a continuum of muscular weakness.
Great. Someone earlier had asked about other medications, both to see if there could be a drug-drug interaction with the statin, as well as to think, are there other drug-induced autoimmune conditions? I think someone mentioned drug-induced lupus. The other meds are lisinopril, metformin, saxagliptin, and that's it. No known family history of cancer or autoimmune conditions. On social history, probably the most remarkable thing to mention that arguably could even be in the HPI for this is pretty heavy daily alcohol use, 4 to 5 beers, but no cigarette use at all. No allergies. And let me just give you guys the exam and we can stop from there. His vitals are completely normal. Generally, he looks well. He doesn't look emaciated or cachectic in any way. A focused lung exam is done because of the shortness of breath he's feeling. His lungs are completely clear without any wheezels or crackles. On abdominal exam, there's no palpable masses anywhere. He doesn't have any tenderness. And then on neuromuscular exam, in his proximal lower extremity, so essentially when testing his thighs and hamstrings, he's got 4 out of 5 strength. Distally, he is 5 out of 5 in the legs, and he has probably 4+ out of 5 at the shoulders, and is distally 5 out of 5. He's a little tender on that muscle testing, actually, but his muscle bulk and tone looks normal. His reflexes are normal. And on the skin exam, actually nothing is seen at the time of this exam on the hands, on the neck. To be very fair, looking for some of the non-exposed areas of the skin wasn't done, but looking at where it was available with his clothing, the hands, the neck, were normal.
Interesting. So the rash is something like he had noticed and
Yep.
then it went away.
Yep.
What do y'all think, friends? So okay, let me ask some questions then. I guess is our hypothesis that this is myopathy confirmed by the exam? Yeah, right. The muscular tenderness is a good one. Intact reflexes, no sensory deficits, and then a proximal predominance of the distribution, all like textbook for a myopathy. Okay, next question. I guess this is something Ravi was starting to think about, is like how to connect the the dyspnea. So antisynthetase syndrome with associated ILD, which by the way tends to be really, just progressive and malignant, is one possibility. What else? How else can you connect the dyspnea here? Let's make a list. Okay, so diaphragmatic, another kind of chest wall involvement. Absolutely. I think it's so easy to miss weakness from muscular dyspnea from muscular weakness. One of the things that should sort of like clue you in is like someone's short of breath, especially with exertion, but like the lungs are clear, chest x-ray is clear, oximetry is normal, right? Yeah, it's and then you can do like a negative inspiratory force or some provoking maneuver to see if it's actually a ventilatory problem with weakness. Anemia, okay, we're thinking cancer. We could have a PE. That's a good thought. Austin, if you're able to elaborate on endocrinopathy, can you share more what you're thinking? Is that for the dyspnea too?
Sure. I mean, I'm not sure it applies completely to this case, but I think in someone that has sort of, oxygen levels are normal, the physical exam isn't cleaning in one particular direction. What gives you sort of like image negative or exam negative dyspnea? And so we can think about, anemia. We can think about the neuromuscular weakness, as was mentioned, the pulmonary embolism. You might have more, vital signs of that or other syndromes of that. And then endocrinopathy. I think it speaks more to just like the weakness and asthenia, like in general, the adrenal insufficiencies that can always present it's very hard to make a diagnosis of adrenal insufficiency, at least in the outpatient setting, in my experience. So that's always on the thought. And then thyroid related disease, especially in an older person, you can have like hyperthyroidism that could present as this, has a particular terminology. I think I'm blanking on it. It's like thyroid apathy or some, I'll put the term, put it in the chat, but the thyroid and the adrenal gland are always on the hook, at least in my opinion. So that's why I thought of it.
I love that. Yeah, until we see the labs back normal, I should say appropriately normal, because right with endocrine, it's always, is it appropriate or inappropriate? Yeah, they're on the hook. I love that teaching point.
That was awesome. Thank you. Yeah, I think, and then there's a lot of ways that, both weakness as well as the possibility of cancer can cause problems in the lungs, right? So you're weak, especially when you're weak swallowing, you're at risk for aspiration, right? You have cancer, it could be in the lung to start with, it could go to the lung, it can go to the pleura, it can cause effusions, PE was already mentioned. So the whole world of kind of pulmonary pathology opens up whenever you have either malignancy or something that is just impairing your normal kind of muscular function, including of all the things that muscles do to help keep sterile places sterile. Okay, so we need some imaging, we need some labs.
Let me give you the first pass labs and imaging. Let's see, on the CBC, the white count is 22,000 with neutrophilic predominance. Hemoglobin and platelets are normal. On the BMP, sodium is 123, potassium 4.9. There's no anion gap. Renal function is normal, BUN and creatinine. Well, creatinine is 0.6. FOS is normal. And then in the liver biochemical tests, AST is 396, ALT is 360, CK is 5,700. The Billy, the Alk Phos, the albumin are all normal. The albumin is 3, but the rest of the liver panel is normal. UA has 4+ blood, 2 red blood cells. ESR is 29. CRP is 12. And then both a chest X-ray and then a CT are done early in the evaluation, both normal. And I'll leave it there for now.
Hans, blood is in a UA is myoglobin, absolutely. Do we have a TSH, Steph?
TSH is normal.
Okay. Austin is very reassured.
Oh, wait, I apologize. TSH is 9.
Okay.
TSH is 9.
Austin is still very reassured.
Free T4 is normal.
Okay. What do people think of the ALT, AST?
The BUN and creatinine are normal, and the CK is 5,700.
5,700.
Yeah, 5,700.
I guess I'm kind of going backwards, but so we'll talk about the white count in a second, but anybody have thoughts about these like elevated quote unquote liver biochemical tests? Anybody worried about the liver? Boston's saying they're explained by the muscle injury. So yes, so skeletal muscle does have ALT and AST in it. It's a lot more AST than ALT. So usually if I sustain a crush injury right now and my CK, goes up to 50,000 because I kill a bunch of skeletal myocytes, my AST would probably be like 2,000 or 4,000, and my ALT would be about a quarter of that. But then AST has a much shorter half-life, so it comes down faster. So sometimes, depending on like the timing of the injury or in chronic muscle injury, you can have a little bit more of like equal AST and ALT, and it still be from the muscle. That being said, whenever the ALT is like this, where it's like as high as the AST, and when you're talking about cancer, it could be anywhere or whatever, I wouldn't forget about the liver, and I would still want to look at it in terms of imaging. Okay, Austin, you were thinking about the white count and inflammatory markers. Do you want to elaborate?
Or the discrepancy right there.
Yeah, I mean, I think whenever you see signals of inflammation in the history, like with the weight loss and the general kind of symptoms, and then see an elevated white count of 22 without any clear history of infection or right now, we could certainly invoke malignancy or autoimmune disease, as we've already sort of discussed. But then seeing the normal inflammatory markers are a little bit discrepant, because usually those things would sort of coincide. But in some of the inflammatory conditions like myositis, you can see normal inflammatory markers. And then I have to say, I don't know, in my clinical experience, I think although we sort of always invoke, at least in my training, we're like, oh, ESR CRP is just going to be high anyways because they're here in the hospital for this or for that. We don't really use that in the clinic. Sometimes we're like, okay, I guess we're going to check it, and it sort of surprises you when it comes back normal. But just like every other test, they have their limitations. They're one data point, and so I don't think it pushes us away from an inflammatory process right now. I think it's just interesting to see the discrepancy. But I've certainly seen a few patients where we were concerned about an autoimmune disease, and we get the inflammatory markers, and they sort of we were using that to sort of reassure ourselves that maybe that wasn't going on. But with more time, it's not that they necessarily changed, but the patient's condition changed, and then eventually we were able to diagnose them with autoimmune disease or whatever the other underlying inflammatory process was going on. So I think it's interesting, but it doesn't necessarily shift my post-test probability very much just because of the
Great discussion. I mean, I would just interpret the totality of those inflammatory markers as he has systemic inflammation. The CRP is elevated, right? And just keeping in mind that the ESR is more of it's the A1C of inflammation, right? So You know, if I watch a scary enough movie right now, my white count might be 15 right after, just from that immediate cortisol release. And similarly, CRP can go up, you know, over hours or days. But so maybe there's sort of a process that is kind of accelerating and the ESR is just lagging behind. But I agree, they're definitely they're still helpful tests, even in the inpatient side, in my opinion. So people start talking about the hyponatremia a little bit in the chat, which is great. It's not a trivial hyponatremia. 123 is pretty low. Seems like he's not overtly volume overloaded, certainly, and there's not too much of a context of volume depletion either. So we're in the euvolemic category. You know, I would kind of want to know a little bit more about his kind of fluid and solute intake potentially. Urine, the specific gravity on that urinalysis would be helpful. Austin, we're thinking along the same, we're on the same page here.
And the spec grav is, yeah.
What is
Oh,
that?
sorry. I just typed
That's the most concentrated urine I've ever,
Sorry.
ever heard of.
1.011. My
His
apologies.
urine is salt water.
Yeah.
1.0. Okay, so it's kind of isostenuric, yeah. About isoosmolar, which definitely means, you know, the SIDH isn't suppressed. This isn't just like, you know, drinking too much Topo Chico, if there's such a thing. But so yeah, it could be SIDH, or we've ruled out one endocrinopathy. We haven't ruled out the other, especially with that high potassium. There could be adrenal insufficiency as part of this syndrome, or, you know, or unrelated. Oh my God, why am I blanking on what copeptin is? Can someone help us out, Moataz? Is that oh, it's like co-secreted with ADH? Is that the other term for ADH?
ADH breakdown.
Yeah,
Interesting.
yeah.
Cool.
Has anybody actually used that assay? Have it available? Yeah, me neither.
Yeah, interesting.
Good evening.
Mhm.
Cobiptin can I used it before as a marker for acute coronary syndrome in patients like in CKD patients or end-stage renal disease patients for confirmation of acute coronary syndrome. And also cobiptin is a breakdown from vasopressin. Can be used to as a surrogate marker for increase of vasopressin or ADH.
Very cool.
Yes.
Thank you.
Thank you, Moataz.
Thank you very much.
I forget if it's Beatrice or Valeria scribing, but I think the spec graph was 1.010.
Yeah,
Not
1.011, but yeah. Yep.
Yeah, okay.
Let me give you guys some more info. Brought up some great points here. Given the AST, ALT elevation, a full CT abdomen pelvis was not done, but a right upper quadrant ultrasound was. And that just showed a slightly enlarged liver with kind of a heterogeneous echo texture. Cortisol axis testing was normal. And A1C was checked, came back at 7.5. If anyone cares, his LDL on the statin was in better shape than it had been. It was 92, even though he had been off it a week. And aldolase is checked to further kind of just look at myopathic injury. That's elevated at 20. Upper limit of normal is 10. Are we missing any initial data you guys want? Otherwise, we can figure out what we want next.
Yeah. So yeah, I think we should sort of shift the focus to management now, and kind of more specific diagnostics. But one thing I did want us to kind of think about is what's up with that rash going away on its own? Can dermatomyositis do that? Austin's saying, I don't know enough about it, but if they can flare, be transient.
Whether stopping the med itself.
Oh, interesting. What if this was somehow mediated by an external exposure, which was then withdrawn? Yeah, I think all of the above is possible. And I do think, at least I personally over time have underestimated the degree to which sort of what we think of as, diseases that once you have, or that tend to be progressive most of the time, but just things kind of going like this on their own and living their own life. And people who live with autoimmune disease will tell you that, like, on the same treatment, everything else is like, seems to be steady state, but like their underlying disease gets better and gets worse. And sometimes they have good days and bad days, good weeks and bad weeks. Whether that's talking about their like joint pains or their diarrhea or whatever manifestation of autoimmune disease they tend to experience. And in fact, like even malignancy, the thing that you think of as like, so sort of like the most progressive process that you can imagine, there's always a battle between the cancer and your immune system, right? Even when you're not on checkpoint inhibitors. And low-grade lymphomas, for example, it's very well documented that sometimes the lymphadenopathy can increase and decrease over time. Again, overall, having, of course, a big picture progressive time course when it comes to malignancy, but again, some fluctuation even without treatment, certainly for autoimmune disease, is not out of the question.
I just think that fluctuation of disease is so important. I think when we do a problem representation, for example, like a case like this, we end up including the data that we see in front of us. But I think if we were to summarize this case now, what I'm hearing is you guys are still factoring that into your thinking. And so framing this as a 70-year-old man, progressive proximal muscle weakness, recent statin use in a evanescent rash, a rash that came and went, I think is still important. I just mentioned that because I feel like it happens. We have so much information coming at us. A patient will report a symptom or a finding that we don't corroborate now, but it doesn't mean it shouldn't be part of our thinking of that, right? Like the patient's experience of what they've been through and whether it's there at the moment we examine them is still such valuable data as much as a sodium of 129. So I just like that reflection a lot.
I'll add to that real quick and say that when I was discussing this case of with the neurologist of the muscle weakness that was actually bradykinesia, I used the word subjective. I said, no, it's just subjective weakness. And he was like, you mean patient reported? And I was like, oh yes. And and I do think we draw this like distinction. We're calling symptoms subjective, and then radiology reports objective is not quite fair. But anyway, so let's talk a little bit about like what we would do next for this patient. We have a strong diagnostic hypothesis. What are the next steps?
Ravi, I just saw such a good thought, right? He has diabetes, I added the A1C because it's under pretty good control now. But yeah, there's a lot of myopathic complications of diabetes, including this diabetic muscle infarction, this amyotrophy, such a good thing to have on there. It's typically is, right? The big muscles of the thighs where people just have weakness, but a very predominant, like excruciating pain in that region that often has no footprint in terms of CK elevation. You can absolutely see changes on MRI. So that's a great thought just in general for muscle symptoms in someone with diabetes. Just wanted to comment on that. Awesome point. So Gurbani's saying
biopsy, serologic testing, autoantibodies, which these days it should be a panel. All right, you should be sending a list of autoantibodies if you have access to them. That is hard to remember because it's not just anti-synthetase, it's not just anti Joe and me and the handful that we knew about 10 years ago. There's now like a couple dozen actually.
Myositis antibodies.
Yeah, it's a myositis antibody panel now, just like we have an autoimmune encephalitis panel, right? And I would definitely involve rheumatology as the specialists who are kind of at the leading edge of knowing the best way to approach this. David, I love that point you're bringing up. We need biopsy, but whether an MRI can point to the preferred site, and I've actually come around to believe, and I think this is sort of what I've heard from a couple of rheumatologists now, that it's almost always worth doing, because I'll never forget this image. Let me just try to pull it up. I know I tweeted it once. Like the muscle involvement can be so patchy, even though it's a supposed to be a diffuse, right, disease. Some fibers are going to be involved and some are going to be spared. So here we go. Perfect. Okay, let me share the screen. Okay, are y'all seeing this MRI now?
Mm-hmm.
I know you are, Steph, because we're looking at the same screen. Same screen.
I'm just excited to see the image.
So look at that, right? And you can just imagine if you biopsy this like vastus medialis or whatever this one here is, that's totally normal, as opposed to this one that's all inflamed and T2 hyperintense, right? You're going to get a false negative versus a diagnosis. So I think this is the reason why, if you can get an MRI within resource limitations, et cetera, to guide the biopsy, it's important.
Okay. And ANA is normal. Myositis panel is sent, but does not come back quickly. So I'll hang you in suspense momentarily. He actually got an EMG as the first sort of muscle specific, essentially to confirm sort of pattern of myopathy versus other neuromuscular cause for weakness. And pretty much all the muscles tested were abnormal, showing a myopathic process. He also had a mild sensory motor axonal neuropathy that was thought kind of unrelated and perhaps from the diabetes. But with the EMG, the report actually said, can't distinguish between severe toxic myopathy and myositis based on these findings. They just know the muscles are diffusely sick everywhere they check them. The myositis panel comes back, and all the standard autoimmune myositis antibodies are actually negative. But you guys mentioned an additional one that should be checked because of the drug exposure in this case, the anti-HMG-CoA reductase antibody, and that comes back extremely positive. And he actually didn't get a muscle biopsy at all. It was sort of based on this clinical picture syndrome. And I don't have the exact number with me, but a very, very high titer HMG-CoA reductase was thought to be statin immune mediated myositis. And so in addition to the statin being off his med list forever, which had already been off, he was put on immune suppression with steroid and azathioprine, and it got better. So I've got just a couple kind of reflections on the case and things I learned from it, but just, yeah, would love to hear any other thoughts or insights from you guys.
What's up with the rash?
What's up with the rash? Okay. Point number one that I had no idea. Sorry, Siri didn't know either. Statin mediated autoimmune myopathy can be very inflammatory. So in retrospect, his weight loss was thought to actually be related, not just to the decreasing oral intake with the sort of more acute onset dysphagia before, but actually the autoimmune syndrome inflammation itself explained the white count, the mild CRP elevation, probably the inappropriate ADH elevation. So it's an inflammatory condition. So it can be associated with weight loss, fevers, and it can be associated with a rash that looks very typical of dermatomyositis rash. In this case, it came and went, which is known. Typically, it does stick around more. So this is a very tricky diagnosis to make. Of course, a good medication history is critical, but it can really look like a primary autoimmune, not drug-induced myopathy with some of the inflammatory as well as skin changes that can happen also. which did happen in this case. The dyspnea, the difficulty swallowing, it was all thought to be muscle related, both with the neuromuscular bellows function of the lungs, as well as actually some early bulbar involvement. So it was very fortunate this was diagnosed and managed quickly. So yeah, I didn't have that concept of this being a very inflammatory myopathy leading to those other findings and symptoms also with skin involvement sometimes.
Wow, amazing.
The other just kind of reflection I had is I think someone put in the chat, I mean, this is very rare, right? So just take into account in general, true statin myositis is maybe 1 in 10,000, but you take the autoimmune induced statin myopathy, and that is a 10th even more rare. So this in no way, right, should scare us from using statins. That's the kind of thing with these very rare, very morbid diagnoses. Should this affect our practice in terms of who we manage? Absolutely not. This is an extremely rare and unique diagnosis in this case.
Very cool. Thank you, Steph.
Motaz has a good question here.
Seems like Ravi might have answered it.
Ravi answered it. Awesome.
Although I didn't click on it.
Great.
Thank you, Steph. I guess people can kind of share their favorite take homes or any other questions in the chat while we review everything through the teaching points.
Yes, this was an amazing case and discussion. Thank you, Steven and Steph. So starting with the teaching points, we will begin with a very vague chief concern, which was weakness. However, the pattern of weakness that the patient described, which was more proximal, pointed us to the possibility of a muscle involvement. And Steven shared with us the possibility of spasticity being a mimicker of weakness due to patients perceiving that they cannot complete movements. So it can be interpreted as such as well. And then we discussed about the effects of a statin or the possibility of a statin-induced muscle toxicity, which can present in 2 ways, either direct insult of the medication, which I think is the most common one, and then the immune-mediated necrotizing myopathy, which is the one in this case, that is because of antibodies against HMG-CoA reductase. And the statins which have the highest risk for these 2 toxicities are atorvastatin, rovastatin, and simvastatin. And usually, clinically and laboratorily will look like inflammatory myopathies. And then the rash pointed us to the possibility of this being dermatomyositis, which, especially in young people, we should rule out malignancy, which can present with the dermatological part, which include rashes in photoexposed areas or not so photoexposed areas, such as the Steph shared, like the subtle side rash, and also mechanical hands, Gottron papules, and periungual erythema. And then we have the muscular involvement, which is proximal, and laboratory markers that can include a panel of antibodies, elevated muscle enzymes, and as well as the findings on biopsy, and in which we can use the MRI to point us of the best place to have the biopsy. We also discussed about imaging and exam negative dyspnea, which was the case in this patient that had bulbar involvement as well, in which we should consider muscle weakness and anemia and endocrinopathies that can also present with dyspnea without a lot of other symptoms. A pearl that was shared as well was that in rhabdomyolysis, usually we have an increase of AST versus ALT predominant. And we also discussed about the possibility of diabetes explaining the muscle injury, which could be due to a spontaneous myonecrosis or infarction, and also amyotrophy, which can present with exquisite tenderness on palpation, usually in lower extremities, and swelling. So thank you for this amazing case. It was great.
Thank you, guys. And just one quick thing in case anyone looks at this sheet in the future. So the diagnosis at the bottom of the middle panel, it's statin-induced autoimmune myopathy. Really important thing, because In this case, the pathophysiology is the drug is stopped, but the destructive antibody is formed already and perpetuates without the statin. So that's what differentiates it. And that's why immune suppression, the steroid plus the azathioprine this guy was on, was part of his treatment there.
Thank you, everybody, for joining
Thank
us.
you.
Great to see y'all. Thanks, Valeria and Beatrice, for the board. Hope everyone has a great day.
Thanks for letting me share, everyone. Great to see you. See you next time. Bye.